Hi, so we're going to talk about the child with cardiovascular dysfunction. Our objectives are here is to discuss and differentiate between congenital and acquired congenital heart defects. So first I want you to go ahead and review a normal heart. So what we need to do is start with the basis of a normal heart. So go ahead and review what a normal heart looks like from your textbooks or from your physiology classes, how a normal heart works, how it pumps, and then we can talk about how a dysfunctional heart works as well. So a congenital, there are two types of dysfunction, congenital and acquired dysfunction. So congenital means basically they are born at birth with this dysfunction. It's an anatomical dysfunction that happens sometime when they're developing and they have this cardiac defect from birth. The second one we talk about is acquired. This is that they weren't born with it, that they acquired it either from a disease process, an infection, autoimmune response, environmental factors, or family tendencies or family inheritance. So when we talk about doing a cardiac assessment, first we ask about their nutritional status. So we're going to find out if they're of normal weight, if they're normal size. Also look at their color of their skin. Are they pale? Are they showing signs of cyanosis? Do they have chest deformities, unusual pulsations? Are this cap refill normal? Is their heart sounds normal? Do they have any murmurs? So we're also looking at how hard they're working to breathe, because the harder the heart works, the harder their lungs work. So what is their respiratory rate, and are they using accessory muscles for breathing? Also looking at clubbing of the fingers. So if they have a prolonged hypoxemia, they will have indications like clubbing of the fingers, or a failure to thrive type of presentation. They will be smaller than normal. They might have a bigger head than normal because all the blood is shunted to the head because of the cardiac dysfunction. So look at basically, are they a normal size? Do they have normal functions? Is their respiratory normal? Is their heart normal? Do they have any extra beats? Do they have any murmurs? So that's where we start off when we're doing our assessment of the cardiac system. Um, Also, you're going to look at their, again, looking at their chest, looking at see if they have any pulsing, if you see the heart pulsating in their chest, if you see the jugular venous dissension. You're going to look at their abdomen. You're going to feel for their peripheral pulses. Are they strong? Are they weak? You start with, if they're weak peripherally, so you have a weak pedal pulse, then you move up the legs to the popliteal pulse, and then the femoral pulse to see where the strongest pulses are. Heart rate and rhythm. Is it tachycardic? Is it bradycardic, and what rhythm is it? Are they having an ectopy, which means are they having extra beats in that rhythm? And what are the heart sounds? Are they muffled heart sounds? You hear murmurs? So all these things we're doing when we're assessing the pediatric patient for cardiac defects. So cardiovascular dysfunction, we're also going to listen to them. We're going to listen to how their heart sounds again. When we talk about the rhythms, listening to those murmurs, finding out where their heartbeat, you might hear different abnormal sounds at different locations when you're listening to the heart. And then diagnostic evaluation. So when you are diagnosing heart defects, they're going to do a couple different tests that you need to know about. First of all is the electrocardiography, or EKG or ECG. This is when they're looking at the electrical impulses of the heart. So they put a 12 lead, what they call a 12 lead EKG on, where they can look at different parts of the heart, the anterior, the posterior, the apical, parts of the heart to see where they might have a dysfunction in their cardiac electrical impulses. So this is just measuring their electrical impulses. Echocardiography is an ultrasonic imaging of the heart to look at the structure of the heart. So you're looking at the structures of the heart, looking at how they are working, whether you have a valve that's leaky or if you have any blood flow that is going from left to right, if they have a hole in the heart or they have any mixing of blood. So they're looking at the structure of the heart and how that is working. So when you might do an MRI, and that is looking a little bit more in depth at the structure and the soft tissues of the heart and the surrounding area. And then the really diagnostic test is going to be your cardiac catheterization. So that's when they thread a wire and look at the heart to diagnose, look at the pressures of the heart, of the different parts of the heart, the right side of the heart and the left side of the heart. So it can be a diagnostic. It could also be interventional. So they can go in and they could actually maybe close an ASD or a VSD through this catheterization. And then they could do EP studies, electrophysiology studies, where they're looking at the conduction of the heart and maybe finding those areas that are malfunctioning, and they can go in and fix those areas that are malfunctioning, misfiring. So talking about congenital heart disease, or CHD, occurrence about 8 to 12 per 1,000 births, so it's not uncommon. It depends on the severity, though. Everyone can go from very mild to very severe, to a patient that can, have very few symptoms, to a patient who has a life-threatening congenital defect, so that they would need to be fixed right after, or it might be fatal for them. So it is also the major cause of death after in the first year. And the most common anomaly is going to be your ventricular septal defect that you're going to see. And often cardiac defects are associated with other genetic anomalies like trisomy 21 or 13 or 18. So you might see them in a syndrome. So heart defects can be associated with something called the CHARGE syndrome or Bacterial syndrome. So it can be associated with other anomalies at birth, not just cardiac. So it's interesting and important to understand the differences between the fetal circulation and the actual circulation after birth. So, and what those transitions are. When they're a fetus, they're getting their oxygen and their nutrients from their mom, from their placenta, and blood is delivered to appropriate places. You have a couple different openings that are there during fetal circulation that should close after they're born. One of those is the foramen ovale, and that is a little hole in between the right and left side of your heart. And then the ductus arteriosus is a hole between your aorta and your heart, or connection. So after the umbilical cord is cut, pressure changes in the lungs should cause these things, the foramen ovale and the ductus arteriosus, to close as blood flow goes to the lungs, because during fetal circulation, as you know, blood flow doesn't go to the lungs. Because they're getting their oxygenation from their placenta. So after birth, this changes. They start breathing, taking in air in the lungs, which changes the pressures in their circulatory system, which should make these things close. So there are two different types of congenital heart defects. We will either say they're acyanotic or cyanotic. It's very important to understand the difference between the two. Acyanotic means that it has normal oxygenation, that there's a defect, but it does not affect their oxygenation. And the cyanotic defects affect the oxygenation. So you're going to see patients with lower oxygen in their system. So you're going to see lower saturations or oxygen saturations in these patients. So acyanotic means, in red, means they are normal, and cyanotic means that they are blue. So we classify the defects based on when blood flows from an area of high pressure to one of low pressure. For example, if you have an ASD and you have higher pressures in the left side of the heart than the right side of the heart, you're going to have blood flow from the left side to the right side because the pressure in the left side is higher than the pressure on the right side. And you also understand that blood also takes the path of least resistance. So you can have a left to right shunt, meaning it goes from the left side of the heart to the right side of the heart, or you can have a right to left shunt where blood will go from the right side to the left side depending on the defect and the pressures in the system. So when we talk about increased pulmonary blood flow, meaning that the defects will cause an increase of blood flowing to the lungs, which has its own complications. You have an abnormal connection between the two sides of the heart. So if you have an increased blood flow into the right side of the heart, because the right side of the heart is sending out blood to the lungs, and you add more blood to the right side of the heart, so it has to work harder to send more blood to the lungs. And that increases the pulmonary blood flow. And you have maybe a decreased systemic blood flow because that blood that should be going to the system is now going to the right side of the heart and to the lungs. So the pulmonary system might have a higher pressure and your systemic pressure could be lower than the pulmonary system. So some of these are that can cause them are the atrial septal defects, ventricular septal defects, and PDAs, or patent ductus arteriosus. And those are all going to depend on the severity of the defect, on how much it's going to affect the blood flow. Smaller defects are going to be less symptomatic, as larger defects will, as you can imagine. Then we have obstructive defects. So these are defects that can have a narrowing or stenosis of a vessel or even a valve, and that can cause obstruction of the blood flow. So some of those can include coarctation of the aorta, which we'll talk about later. Aortic stenosis, which means that the aorta is stenosed, it's smaller and less flexible. And then maybe a pulmonic stenosis. Again, it can be a smaller, it will be smaller, so it would obstruct the flow that should be going through the pulmonic into the lungs. So you have an obstruction, an anatomical obstruction right there. So talking about decreased pulmonary blood flow, what causes a decreased pulmonary blood flow is an anatomic defect between the right and left sides of the heart, where the pressure on the right side is increased, exceeding the left pressure. So of course, if you talk about pressures of path of least resistance, the blood is going to flow to the side that has the lower pressure, from the side that has a higher pressure. So if your right side heart has higher pressure than the left side of heart, and if there's a connection between the two sides, you're going to have blood flow that goes from the right side to the left side, and that is going to decrease pulmonary because your right side usually pumps blood to the lungs. If they're not pumping blood to the lungs, it's going to the right side, left side of the heart. It's pumping to the systemic system. So you get desaturations because that blood that's in the right side should be going to the lungs to get oxygenated, is not. So you have the blue blood going to the left side and getting pumped out to the systemic system, which will decrease oxygenation of your systemic system, and that's when you get the lower saturations. So think of it, the blue blood mixing with the red blood, that blood, because what you want is the red blood, the fully oxygenated blood from coming back from the lungs going into your systemic system, and now you're mixing it with like deoxygenated blood, then you're going to have a lower blood saturation. So this is where you're going to get your hypoxemia, and it's your cyanotic defects. They're going to have cyanosis, meaning they have bluish tint around their mouth. They can have bluish tint at their fingertips or their feet. They're going to have their perfusion is going to be compromised, so they can have cooler extremities compared to the rest of their body. They can have a delayed cap refill, and less oxygen is also going to the head. Another one of these defects is called tricuspid atresia. So when the tricuspid valve isn't formed or is malformed at birth. And then you have some mixed defects, and this happens with a lot of complex cardiac defects. You can have both, kind of a mixture of cyanotic and acyanotic, and it usually results in the desaturation and also can cause CHF or congestive heart failure in patients. These defects can include transposition of the great arteries or vessels. That means that, they're going into the wrong place, where the IVC or the blood that's supposed to be dumping into the right side of the heart is now dumping into the left side of the heart. And then the blood that's supposed to be going to the lungs may be going from the left side to the systemic system instead of out to the lungs. So there's a lot of complications and complex and anomalies that can be associated with these. You can have a total anomalous pulmonary venous connection, truncus arteriosus, and hypoplastic left heart syndrome. These are all what we call mixed defects. The other one I wanted to highlight would be maybe the hypoplastic left heart syndrome, and that is where your left side of your heart, or left ventricle, is basically you're not functioning. It really is non-functioning part of the heart. So you're only functioning ventricle. You'd have the left and right atrium, and then the right ventricle would be only really functioning parts of the heart where that left ventricle is not. So they have several surgeries that will help them to increase blood flow to the lungs and increase oxygenation so that they get the right amount of oxygenation out to the rest of the body. So when we talk about congestive heart failure, this is when the heart is not able to pump blood adequately to the body. You can have lower cardiac output. And in that case, you can get congestive heart failure because everything is affected by that. It could be congestive heart failure can be a result of a congenital defect, or actually even an acquired defect, possibly. It can be a result of either right or left-sided failure. So either side of the heart can fail, and you can get congestive heart failure where the body is not able to, your heart is not working effectively enough to pump enough blood out to the body to meet its needs and its demands. So when we talk about management of congestive heart failure, we talk about improved cardiac function. So how do we improve that cardiac function? We can do it by with medications and surgical interventions. So improving the function is our goal. We can also help by removing fluid and sodium that is accumulated in the body, because the heart's not functioning well. Usually the kidneys are not functioning well. So there's usually a buildup of fluids. So we need to get rid of those fluids somehow. And a lot of times we do that through medications as well. We decrease the cardiac demand. So if your heart isn't pumping efficiently, we need to make sure that we allow the body to rest, and so that we don't put extra pressure on that heart to function. So we decrease their cardiac demands. Strategies used to decrease your cardiac demands would include clustering your care. So make sure that you go in there and you disturb the patient all at once, and we don't go back in there multiple times because we forgot something or we need to do something else. We do everything at once so that in between our interventions we let the patient rest as much as possible. Basically, that is the most effective way to decrease your cardiac demands. We keep them comfortable as well. If they're in pain, we give them pain medication. If they have a temperature, we treat that temperature, because a temperature is going to put extra metabolic demands in your body, and your heart's going to have to work harder. So, and we make sure that they're normothermic, they're not too cold and they're not too hot, so that we can keep their body in kind of as much of a homeostasis stage as we possibly can. We improve their tissue oxygenation, and a lot of times we do that either through medications, and we can do it by administering oxygen. Sometimes they're on oxygen because they don't get enough, so we have to give them supplemental oxygen to help meet their demands of their body. So you need to maximize their tissue oxygenation. So when we're caring for a patient, we assist in improving their cardiac function. So basically, like I said, We will cluster our care, we administer medications, we give oxygen, we keep them nice and calm, we monitor. So we need to monitor after load reduction, so make sure that they don't get too much fluid on board to make their heart work harder. We decrease their cardiac demands by making sure that they're normothermic, that we don't stress them out, that we keep them comfortable, that we keep them out of pain. Reduce their respiratory distress, same thing, maybe give them a little bit of oxygen, keep them out of pain, keep them comfortable, make sure that they don't get too upset. We like to console these babies and make sure that they're very happy so that they can not put more stress on their heart when they're in failure. Nutrition is very, very important because of the cardiac demands and the metabolic demands. We need to maximize their nutrition. We need to make sure that they're getting the appropriate nutrition and the appropriate calories. That will be dependent on the age and the size of the patient, but we need to make sure that they are eating, if they are eating formula or if they're able to eat a pediatric diet, that we monitor how much is coming in and how much is going out. It's very, very important to have strict I's and O's for your cardiac patients. We also need to make sure that they're getting those calories because their heart is working harder, they're using more calories. We need to make sure that they're getting those calories. And the very last thing is we need to make sure that we support their family. We need to educate them. We need to use therapeutic communication, listen to them, use therapeutic listening, make sure that they have all the information that they need, that they also take care of themselves. Mom and dad need to take care of themselves. I always tell mom and dad they need to take care of themselves because then they need to go home and take care of their baby once they do go home and they have the opportunity to go home. So make sure that the family is supported and use your consults to help out case management, social work, child life. Use everything, the resources that are available to help out the family while they're there. So we talked a little bit about hypoxemia and cyanosis. Basically, we need to understand that hypoxemia is when you have less oxygen in your blood. It's less arterial oxygen tension is less than normal. We don't have enough circulating blood. We see this by a decrease in oxygen saturation. Also, we can see this with cyanosis. So if they have the blue around their lips or blue fingertips or blue toes and decrease in perfusion and decrease in cap refill. Polycythemia, which means that the way that these patients will compensate is they will produce more hemoglobin and hematocrit so they can have more oxygen carrying capacity. So polycythemia is pretty normal for them. They have a higher baseline hemoglobin than most children that don't have a cardiac defect. And then again, we'll see the clubbing. That means that their fingertips are rounded and bigger than the rest of their hands. So we have to monitor for cardiac dysrhythmias. So if the child has a cardiac defect, we need to make sure that they're on EKG. We are auscultating their hearts on a regular basis. We're not hearing new murmurs. If they have a murmur, make sure that we hear the murmur if they're supposed to have the murmur. We are going to monitor for the bradycardias or bradyarrhythmias when they have a slower rate than normal. And sometimes we do make it slower with medication, but you have to know that if they are taking medication that makes their heart slow, that's the responsibility of the nurse to know that. Also, tachydysrhythmias, basically you can have tachycardias, other rhythms that you do not need to know in this, but know that they can get tachycardic. And irregular heart rates. These can be due from their cardiac dysfunction. They can also be due to electrolyte imbalances. So we need to make sure that we check their electrolytes to make sure that their electrolytes are within normal range so that we don't have any cardiac dysrhythmias. Low potassium, low magnesium, calcium, these are all electrolytes that the heart needs in a certain balance to function correctly. And if we are out of balance, we are going to have these dysrhythmias. So we need to make sure we check their labs to make sure that they are within normal ranges. one thing you can have is a systemic hypertension. A lot of the times can be due to other defects such as a kidney defects, but they can also be considered a cardiac. Essential means that we don't know why they have hypertension. They just are born with hypertension and they have essential hypertension. There's no known cause, but it's very important to treat this hypertension and keep it into the normal range, even if we don't know it. And then sometimes there's a secondary cause where it's an identifiable cause. Like I said, it could be because of kidney disease. It could be because they have another comorbidity that is causing their hypertension. But basically what we want to do is make sure that if they have medications, that we give them medications to keep them normotensive as possible. Again, pediatric hypertension is not acquired like adults have. It's usually secondary to structural abnormality or underlying pathophysiology, renal disease, cardiac, endocrine, or neurological disorders. So if you have hypertension in pediatrics, it's not normal. Again, if you have a high blood pressure when you're at clinical, you need to make sure that you address the reasons behind that hypertension. We just don't want to put in a high number, because if it's truly that high, we need to address it with the physicians. Treatments are usually include medication. We can add lifestyle changes, nutrition, education about what foods to avoid that can cause hypertension. And a lot of education on hypertension and the possible detrimental effects that hypertension can have if we don't treat it and we let it go. So I'm going to touch on quickly a couple things before we go into more detailed PowerPoints on some cardiac defects, but multi-inflammatory system disease. This is something that has come up in the last couple of years. We kind of generally term it MISC. So basically it's a immune response to a COVID infection. So it's an immune-mediated response that happens after a patient has a COVID infection. They may or may not have had symptoms from the COVID infection, but this is something that their body their immune system goes into overdrive. Usually this can happen with all ages. They can have fever over 38 degrees Celsius. That is about 24 hours, or subjective fevers that are lasting more than 24 hours. Subjective means that the parents report that there are fevers, but we don't have a definitive, we don't know for sure, but the parents are reporting that they've been having fevers. They have elevated labs, which include their CRP, their ESR. They have elevated fibrinogen, elevated procalcitonin, elevated D-dimers, elevated ferritin, lactic acid, or interleukin-6, elevated neutrophils, reduced lymphocytes, and low albumin. So these are all labs that we would see if we were suspecting an MISC or type of process. There's no other diagnosis that we have for it, so it's basically a rule-out diagnosis. So we're saying if you have all these things, you have a current or recent history of COVID-19, and you have all of these symptoms happening, then we're going to call it MISC. So there's something that's new that's come out in the last couple of years to be aware of. Management and nursing care, we are going to talk about Kawasaki's disease, so it's going to be similar to what we do in Kawasaki's disease, and we'll talk about that in another slide deck. That will include giving medications for it, because this can cause heart and aneurysm or pseudoaneurysms. We need to have a cardiogram, and they need to be followed up with a cardiologist if they have this disease. All right, so we're going to end up with a question as usual. Surgical closure of the ductus arteriosus would result in which of the following? Stop the loss of unoxygenated blood to the systemic circulation, decrease the edema in the legs and feet, increase the oxygenation of blood, prevent the return of oxygenated blood to the lungs. So go ahead and think about this. We are going to actually cover PDAs in another slide deck, so if you want to wait before you answer, when you have more information. All right, thanks guys.